Good morning. Welcome to MHIF Grand Rounds. It's April 15th. Hope everyone submitted their taxes, or if not, they have till midnight, I think. I'd like to thank our exhibitors today for their support of this, Johnson & Johnson and Pfizer. Today I have the privilege of introducing Dr. Katherin Leckie. She is originally grew up in Montana, but spent 7 years in Germany prior to returning for college in Montana. Then she went to St. Louis to Washington University for her medical degree. Following her graduation from WashU in St. Louis, she completed her vascular surgery integrated residency at the Indiana University School of Medicine. That's the modern, for people who are unaware, that's the just a straight track to vascular surgery out of medical school. And then during her time there, she also spent 2 years in dedicated research and obtained a master's in biostatistics during that period. She joined our group in August of 2023, and we're very happy to have her. And she'll be talking today about peripheral arterial disease.
Good morning, everyone. Is this loud enough? Thank you very much for the opportunity to present here and for the invitation. Today I'm going to be talking about peripheral arterial disease, mostly a review, but also some updates based on recent trials. I have no relevant disclosures for today's talk. So the topics I'm going to be touching on under the heading of peripheral arterial disease, I'll talk about the epidemiology and risk factors, pathology and the clinical presentation, a little on the natural history and medical management of peripheral arterial disease. I'll spend some time talking about the anatomy of the disease, intervention options and outcomes, and then for the final portion, some updates based on recent trials completed, the Basel II trial and the BEST CLI trial. So who has peripheral arterial disease? Peripheral arterial disease is estimated to have a global prevalence of around 5.6%, affecting 236 million adults, and maybe as high as 7.4% in higher income countries. The US prevalence is estimated at 8.5 million adults, although this estimate may be off due to changing prevalence of risk factors. Perhaps of more particular relevance to this audience, the prevalence of peripheral arterial disease in patients with coronary artery disease may be over 40%, and in one series of high-risk patients being taken for angiography for unstable angina, peripheral arterial disease was found in over 60% of patients. Patients with peripheral arterial disease have also been shown to have a higher incidence of left main and multivessel coronary artery disease. 25% of patients undergoing transfemoral TAVR have peripheral arterial disease, and not surprisingly, nearly 50% of those undergoing non-transfemoral TAVR also have peripheral arterial disease. The presence of PAD is associated with increased procedural complications and mortality with TAVR. Risk factors for peripheral arterial disease will represent a very familiar list for most of us, as these are the risk factors for atherosclerosis. Risk of PAD doubles with every decade after 40 to 49, and the prevalence of PAD in those over 70 may be over 15%. Men are classically at higher risk, but it has been suggested that this may be explained by the higher prevalence and earlier onset of atherosclerotic risk factors. Smoking is one of the strongest risk factors for peripheral arterial disease and is more strongly associated with PAD than with coronary artery disease. Hypertension is not one of the strongest risk factors for PAD in an individual, but it may be responsible for over 40% of PAD in the population due to its prevalence. Diabetes, like smoking, is also one of the strongest risk factors for peripheral arterial disease and is more strongly associated with PAD than CAD. It is a particular relevance because it is strongly associated with more severe presentations of peripheral arterial disease and by itself accounts for 70% of non-traumatic lower extremity amputations in the US. Hyperlipidemia is also a risk factor. Triglycerides increase PAD risk more than coronary artery disease risk, while LDL is more associated with coronary artery disease, but its association with peripheral arterial disease is less strong. Renal insufficiency is also an atherosclerotic risk factor, which is more strongly associated with peripheral arterial disease than with coronary artery disease. Non-Hispanic Black race and elevated homocysteine levels have also been shown to be risk factors for PAD. It is interesting that while these are all atherosclerotic risk factors, there are different strengths of association with coronary artery disease and peripheral arterial disease among them. A very large study out of Japan highlights this difference in the relative association between cardiovascular risk factors and coronary versus peripheral arterial disease. They looked at over 1 million PCI cases and 100,000 endovascular procedurals for peripheral arterial disease and compared risk factor frequency by indication for procedure across patient ages, specifically for acute coronary syndrome, stable angina, critical limb ischemia, and claudication. One might hypothesize that the milder presentations of claudication and stable angina and the more severe acute coronary syndrome and critical limb ischemia might cluster together, with the latter having a higher frequency across atherosclerotic risk factors. If we focus on the younger patients towards the left hand of each of these individual graphs, where risk factors other than age play a larger role, we can see that in fact coronary artery disease and peripheral arterial disease patients tend to have a different distribution across risk factors. The authors particularly noted that the prevalence of diabetes and end-stage renal disease was 2 and 6 times higher in lower extremity peripheral arterial disease patients than in coronary artery disease patients. So what is peripheral arterial disease? So despite some differences in magnitude, the risk factors for peripheral arterial and coronary artery disease are shared due to their underlying pathology of atherosclerosis. While not the only cause of occlusive disease in the peripheral arterial vasculature, atherosclerosis is the principal cause of peripheral arterial disease. The development and progression of atherosclerotic plaque has been well described, although what is going on the cellular and molecular level is still the subject of active research. In general, intima thickening occurs with smooth muscle cell infiltration. This is followed by an accumulation of foam cell macrophages, and then of extracellular lipid pools. Initially, there is an absence of apparent necrosis, and then eventually a necrotic core forms. Calcification of the necrotic core and surrounding tissue may then occur. Early stages may show regression with risk factor modification and lipid-lowering therapy, but later stages do not regress. While the development and progression of atherosclerotic plaque in both peripheral and coronary artery disease is presumed to be similar, we already noted that there are differences in risk factor associations. On a pathological level, peripheral arterial disease has been observed to have more extensive calcifications of the medial vascular layer, and also noted to have more chronic thrombus not immediately associated with severe atherosclerotic plaque, suggesting a greater degree of embolism or local thrombus extension. I will note that there are other causes of arterial occlusive disease, including embolism, popliteal artery entrapment syndrome, popliteal artery aneurysm thrombosis, larger medium vessel vasculitis, cystic adventitial disease, persistent sciatic artery, external iliac endofibrosis, among others. But for today's purpose, I will be focusing on the atherosclerotic version. The diagnosis of peripheral arterial disease is usually made when non-invasive vascular studies are obtained when a patient presents with either symptoms or exam findings concerning for ischemia. An ABI of less than 0.9 is considered abnormal. If there is significant medial wall calcification and tibial arteries are non-compressible, ABI will be falsely elevated, usually greater than 1.4. In this case, a toe brachial index can be calculated, with less than 0.7 being abnormal. Occasionally, a patient will present with convincing symptoms, but normal ABI, in which case exercise testing can unmask a lesion which is not hemodynamically significant at rest. ABIs are checked after 5 minutes of walking on an inclined treadmill, and a drop to less than 0.9 or 20% from baseline is abnormal. PAD can be asymptomatic or can present with intermittent claudication or with chronic limb-threatening ischemia. Acute limb ischemia can also occur on a backdrop of chronic limb ischemia, but I'll be focusing on the chronic presentation today. It is estimated that 3 in 4 patients with PAD are asymptomatic. Many asymptomatic patients may actually have claudication, but have already modified their activity levels in response and will deny pain when asked, or are limited in mobility due to deconditioning or other medical problems and don't ambulate to the point where they would have had claudication. Intermittent claudication manifests as a reproducible discomfort in specific muscle groups, most typically in the calf, but can occur in the thigh or buttock. This can be distinguished from neurogenic claudication, which is more likely to be positional or occur with prolonged standing. Intermittent claudication likely represents 20 to 25% of all peripheral arterial disease and is the majority of symptomatic disease. Chronic limb-threatening ischemia includes ischemic rest pain or tissue loss, which may present as gangrene or as non-healing ulceration or wounds. 1 to 3% of all peripheral arterial disease is chronic limb-threatening ischemia, and this is probably no more than 10% of symptomatic peripheral arterial disease, although estimates vary widely in the literature, likely due to differences in the study populations. The Rutherford classification of chronic limb ischemia was described in 1986 with revision in the 1990s and was an adaptation of the previously described Fontaine system with the addition of the non-invasive vascular testing parameters and breaking up tissue loss into minor and major categories. There is a Rutherford classification of acute limb ischemia, which is not shown here. The first 3 grades encompass mild to severe claudication. Category 4 is ischemic rest pain. Category 5, minor tissue loss. Category 6, major tissue loss. So intermittent claudication is the most common presentation of peripheral arterial disease, and it has a relatively benign prognosis. In a series of over 1,200 patients with claudication and a mean follow-up of 45 months, but out to 10 years, the 10-year risk of any amputation was less than 10%, with a cumulative 10-year frequency of 18% for any revascularization, 23% for progressing to rest pain, and 30% for ischemic ulceration. In the chart on the right, the study authors calculated the risk of progression to ischemic ulceration or ischemic rest pain, respectively, over 5 years, given a baseline ABI in patients who are presenting with intermittent claudication with or without diabetes. So intermittent claudication tends to have a stable, indolent course with a low annual risk of progression of symptoms or limb loss. Chronic limb-threatening ischemia is a far more morbid diagnosis with a high risk of mortality and limb loss. In over 70,000 Medicare patients with a new diagnosis of CLTI, mortality was noted to be 20 to 25% at 1 year, and up to 50% of these patients have passed away at 4 years. Their clinical presentation was characterized by rest pain in 29%, ulceration in 45%, and gangrene in 26% of patients. 29% of these patients were managed non-operatively. Of the 71% who underwent intervention, the initial procedure was endovascular revascularization, 53%, and surgical revascularization in 21%. Primary amputation was offered to 13% of these patients, which is on the low end of estimates. But the risk of mortality and amputation is hardly homogeneous across the CLTI population. In a German insurance cohort that included 20,000 CLTI patients, outcomes were stratified by severity of ischemia on presentation. The mortality risk at 4 years was significantly different between the subgroups. At 40% in those with rest pain, 52% of those who had presented with minor tissue loss, and 63% of those presenting with extensive tissue loss. Again, this is 4-year mortality. Half of the deaths in the most severe cohort occurred during the first year, which is consistent with the shape of these graphs. The amputation risk at 4 years was 12%, 35%, and 67% in these same groups. And almost 90% of the amputations in the extensive tissue loss occurred within the first year. These curves do include both those who underwent revascularization and those who did not. 30% of those with rest pain did not undergo revascularization, and 50% of patients with tissue loss were not revascularized. Going back to our 70,000 Medicare patients, in a subsequent analysis, mortality and amputation rate were also stratified by severity of ischemia on presentation, with a similar terrible 4-year mortality at 40%, 55%, and 70% for those presenting with rest pain, ulceration, and gangrene, respectively. But the noted 4-year amputation rate was better, at 6%, 9%, and 30%, again, for those presenting with rest pain, ulceration, and gangrene, respectively. Unsurprisingly, in this setting of extreme spectrum of morbidity and mortality, treatment recommendations for PAD are based on the severity of presentation, with the primary goals being to decrease cardiovascular risk and limb loss. All patients with a diagnosis of PAD should be evaluated for risk factors with lifestyle modification and medication as first-line therapy. All current smokers should be counseled on smoking cessation, and patients should be evaluated for hypertension, hyperlipidemia, and diabetes if not already diagnosed. For asymptomatic disease, statin therapy is recommended due to the increased 10-year cardiovascular risk associated with the diagnosis of peripheral arterial disease. Antiplatelet therapy is reasonable, but does not have as strong a recommendation in asymptomatic disease as the data for primary prevention is less robust. There is some evidence that surveillance can find progression of plaque in asymptomatic patients, but as intervention is not recommended for asymptomatic disease, it is unclear whether there is a benefit to surveillance rather than to symptom-triggered repeat studies. Surveillance may be tailored to an individual patient, with those with lower ABIs and perhaps a diagnosis of diabetes being more likely to benefit. For patients with intermittent claudication, again, risk factor modification is foremost. Antiplatelet is strongly recommended in this group, as there is evidence for reduction in all-cause mortality, cardiovascular mortality, and limb events in patients with intermittent claudication. Supervised exercise programs with greater than 30 minutes at least 3 times a week have been shown to reduce leg symptoms, increase walking distance by 50 to 200%, and increase quality of life with durable benefit out to 2 years, and may provide a comparable benefit to revascularization in some patients. Unfortunately, barriers to supervised exercise programs include patient participation, availability, and insurance coverage. While home-based therapy does not have the same data, it is still recommended. Cilostazol or Pletol can improve claudication symptoms and increase walking distance by 25%, but is contraindicated in heart failure, and up to 1 in 5 patients will stop this medication in the first 3 months due to side effects. There is no role for pentoxifylline, chelation, or homocysteine-lowering medications. Annual surveillance is recommended with non-invasive vascular testing, and patient symptoms should be reassessed at these visits. Patients with claudication will frequently request intervention due to concerns about progression or limb loss. Reassurance should be provided regarding the natural history of intermittent claudication. The only role for revascularization in these patients is for functional improvement in the setting of ongoing disability in an active person. The patient should not only be severely limited by their symptoms, but also good risk for the procedure with a reasonable expectation of durable improvement. Greater than 50% at 2 years is recommended. The threshold for intervention will therefore vary from patient to patient based on their comorbidities and the anatomy of their disease. You can also consider the addition of Xarelto 2.5 BID after the procedure based on recent clinical trial results. The Voyager PAD trial randomized over 6,000 patients who had been revascularized to the addition of 2.5 milligrams of Xarelto BID or matching placebo in addition to standard medical therapy. 80% of those patients were claudicants, 20% had been CLTI patients, 2/3 of them had undergone endovascular intervention, and 1/3 open surgery. The primary efficacy outcome was a composite of acute limb ischemia, major amputation of vascular pathogenesis, myocardial infarction, ischemic stroke, or cardiovascular death. At 3 years, there was a statistically significant difference between the arms, with a 15% relative risk reduction. There was an increased risk of major bleeding with Xarelto, but no difference in fatal or intracranial bleeding between the groups. As shown in the graph, the authors estimated that for every 10,000 patients who were treated for 1 year, Xarelto at a dose of 2.5 twice daily added to aspirin would prevent 181 primary efficacy outcome events at the cost of 26 principal safety outcome events. Widespread adoption of Xarelto 2.5 is unfortunately limited by insurance coverage. Patients presenting with chronic limb-threatening ischemia should also have their risk factors addressed, start an antiplatelet and a statin. Unlike claudicants, revascularization is strongly recommended for limb salvage. The goal of intervention is wound healing and preservation of a functional extremity, so a multidisciplinary approach is recommended with medical optimization and added focus on podiatric evaluation and wound care. Depending on the extent of tissue loss, additional debridement or minor amputation will be required in many patients after revascularization. But many patients presenting with chronic limb-threatening ischemia will not undergo revascularization. Primary amputation should be considered in patients with non-reconstructible arterial disease, non-salvageable foot or non-functional limb, and may be appropriate in other patients in whom the benefit of limb salvage does not outweigh their procedural risk. Some patients may benefit from a palliative approach in which limited tissue loss is managed with wound care. But the majority of CLTI patients and some portion of claudicants will benefit from revascularization. Intervention options then are driven by the patient's anatomy. The distribution of atherosclerotic lesions in patients with peripheral arterial disease varies widely. In the lower extremities, we typically consider 3 main segments: aortoiliac, femoropopliteal, and infrapopliteal. Patients can present with disease isolated to one segment or with multi-level disease, and there are strong demographic associations with the distribution of disease. In one series of over 4,000 patients who underwent intervention for symptomatic peripheral arterial disease, 27% had iliac intervention, 50% had femoropopliteal intervention, and 20% infrapopliteal. The authors of this study were able to demonstrate an anatomic distribution association with comorbidities, as shown in the image, with smoking and hyperlipidemia strongly associated with more proximal disease, and age and diabetes associated with more distal disease. It has also been shown in other studies that kidney function is associated with a more distal distribution of disease, a gradient that steepens with progressive renal dysfunction and is most marked in end-stage renal disease. Another series of all-comers with symptomatic peripheral arterial disease found that 2/3 had multi-segment disease. Aortoiliac disease was seen in 51%, FEMPOP in 65%, and tibial disease in 70%. Intermittent claudication was significantly associated with aortoiliac disease, and critical limb ischemia was more associated with tibial disease. Significant associations were found between smoking and aortoiliac and femoropopliteal and multi-segment disease, between diabetes and infrapopliteal disease, and between age and femoropopliteal and multi-segment disease. So very roughly, aortoiliac disease is found in smoking claudicants, femoropopliteal disease in older smokers, tibial disease in diabetics or end-stage renal patients with critical limb-threatening ischemia, and multi-level disease also in older smokers. This is a gross generalization. By convention, the superficial femoral artery and the popliteal artery are considered a single segment, notably in billing as well. But the SFA and popliteal artery are well known to behave differently clinically and to require different treatment strategies. A difference in the underlying lesion pathology is supported by a review of patients who underwent drug-coated balloon angioplasty for de novo femoropopliteal disease and were evaluated for associations between lesion location and their comorbidities. These authors showed that renal failure on dialysis was more associated with more distal lesions, whereas smoking was associated with lesions more proximal in the femoropopliteal artery. This suggests that the SFA shares some characteristics with the aortoiliac segment, and that the popliteal artery has some overlap with the tibial arteries. So rather than representing discrete phenotypes, lower extremity arterial disease is a continuum whose character changes from proximal to distal. In this series, patients with popliteal lesions were more likely to have presented with tissue loss or rest pain, almost 50%, compared to just 20% of those with isolated SFA disease. In general, single-level aortoiliac or femoropopliteal involvement is less likely to present with chronic limb-threatening ischemia, which usually requires multi-level involvement. The exception to this is infrapopliteal disease, which is associated with chronic limb-threatening ischemia even in the absence of significant proximal obstruction. This may be due to the less robust collateral pathways in the calf or to significant concomitant microvascular disease in these patients. Regardless of the anatomic segment involved, options for revascularization can be broadly categorized into open and endovascular. In the last 3 decades, the rapid development and improvement of endovascular tools and techniques has seen endovascular therapy come to the forefront of peripheral arterial disease interventions. And open and endovascular surgery are not infrequently combined in hybrid approaches. In these graphs, we can see that open surgery was more common than endovascular until about the mid-2000s. And in the last decade, endovascular surgery has become 3 to 4 times more common than open surgery for patients with a diagnosis of peripheral arterial disease. Open surgery still has a significant role, however. Endarterectomy is used for focal lesions in surgically accessible locations, most common as a single procedure in the common femoral artery, but also in conjunction with iliac or SFA stenting to optimize, and it is also used to optimize inflow or outflow for a bypass. Aortic endarterectomy is rare, but described for severe focal coral reef plaque. In the popliteal or tibial artery, endarterectomy is usually performed when a bypass target is more diseased than expected. Common femoral endarterectomy is durable and usually well tolerated, and this is an area where stenting is not recommended. Bypass is a technique that is highly adaptable to individual patient anatomy. Patency is primarily a function of the quality of inflow, outflow, and conduit, although technical factors and patient factors also play a role. Conduit selection is based on availability, required caliber, need for external support, and infectious concerns. Autologous vein is the gold standard for lower extremity bypass, with GSV having a superior patency for any below-the-knee bypass. It is also infection resistant, and femoral vein can be used for reconstruction in the setting of aortic graft infections. Unfortunately, not all patients will have adequate autologous vein, and harvest and prep do add time to the case. Prosthetic options include PTFE, usually ring reinforced when used for the lower extremity or for extra anatomic bypasses, and Dacron for aortoiliac or common femoral reconstructions. PTFE and Dacron conduits are widely available in a variety of size and configurations, but are at risk of infection, and extra anatomic bypasses or femoral to below-the-knee bypasses with prosthetic have poor long-term patency. Alternate biologic conduits include cryopreserved cadaveric artery or vein, bovine carotid, or human acellular vessel. These are most appropriate in settings of active infection. when autologous conduit is not available. They have poor long-term patency and can have aneurysmal degeneration or pseudoaneurysm formation. Cryopreserved conduit in particular is expensive, not widely available, and requires meticulous prep. The endovascular revascularization toolbox has expanded dramatically since the earliest simple balloons. Balloon angioplasty now includes high-pressure balloons, scoring and cutting balloons, grooved balloons. Atherectomy includes a variety of tools: directional cutting, laser, orbital. Stents are covered or bare metal, self-expanding or balloon expandable, and drug-coated balloons and stents are also becoming widely used. There are a variety of endovascular adjuncts to these tools, including the variety of wires, catheters, and sheaths with their different configurations and characteristics. There are crossing and reentry devices. Intravascular lithotripsy is becoming more widely used. There are tacking stents in areas where full-length stents are not ideal for areas of dissection. Intravascular ultrasound is extremely useful. Embolic protection devices are available. And suction and mechanical thrombectomy can deal with both primary and secondary thrombotic events. So it's really not surprising that the evidence has struggled to keep up with the options for these patients. The Transatlantic Intersociety Consensus for the Management of Peripheral Arterial Disease was put out in 2000 and updated in 2007. And recommendations have evolved since then, but it does provide a framework for approaching the question. Lesions in a given anatomic segment were classified A through D, primarily based on stenosis versus occlusion and the involved length, with corresponding recommendations for endovascular versus open surgery that were primarily based on the expected durability of the interventions in these lesions. Historical data suggests that long-term patency after aortobifemoral bypass is excellent, but that extra anatomic bypasses fare poorly. While a few of these bypasses are likely being done for claudication anymore, greater than 85% 5-year patency for aortobifem is the benchmark for aortoiliac occlusive disease. And endovascular therapy works very well in focal iliac lesions. This was supported when the Task 2 guidelines came out in 2007, when a lot of iliac disease was still being treated with angioplasty. With stents, there has been an increasing shift towards endovascular repair, even for Task C or D, that is, the more extensive lesions. Self-expanding stents are preferred in areas of possible external compression, as in the distal external iliac artery, and balloon expandable are preferred in the common iliac artery. Additionally, covered stents may do better than bare metal stents in more extensive disease. Aortobifemoral bypass is now usually reserved for young, good-risk patients with extensive disease or for aortic occlusion extending closer to the renals. While an endovascular first approach may be considered in almost all high-risk surgical patients and is likely preferable to extra anatomic bypass when feasible. For femoral popliteal occlusive disease, there is also a task classification, again based on stenosis versus occlusion and the involved length, with corresponding recommendations for endovascular versus open surgery. This has been an area of significant more contention in the last 2 decades. The question of durability of revascularization in the femoral popliteal segment is far more challenging than the aortoiliac segment. For open revascularization, there is a question of conduit, vein versus prosthetic, and of target, above versus below the knee. There is good evidence for the durability of vein bypasses, primarily single-segment GSV, to both above and below the knee. But PTFE bypass patency is significantly lower. Data on endovascular interventions below the inguinal ligament is even more varied. It is difficult to make comparisons, both because of the different tools available, but also because of the underlying lesions cannot be assumed to be the same. Short SFA lesions will do well with endovascular therapy, but there is certainly evidence that longer lesions can also be treated endovascularly, and many approaches may meet the previously mentioned recommendation for intervention for claudication of having an expected greater than 50% patency at 2 years. To note just a few findings, covered stents have been demonstrated to have a 5-year patency for greater than 10 centimeter SFA lesions of 62%. Bare metal stents have a 3-year patency for short SFA lesions of 71% and for longer SFA lesions of 50%. Drug-coated balloon angioplasty has a 3-year patency for SFA lesions shorter than 18 centimeters, approaching 70%. And drug-eluting stents have a 5-year patency for SFA lesions, again shorter, approaching 66%. Two clinical trials comparing bypass and endovascular therapy for infrainguinal disease have recently published their results. Basel II enrolled primarily in the UK from 2014 to 2022, randomizing patients with chronic limb-threatening ischemia to either vein bypass or best endovascular therapy. Patients were excluded if life expectancy was less than 6 months or if they had infrainguinal revascularization in the trial leg within the last 12 months. This trial was termed pragmatic, as interventionalists could use their preferred equipment, devices, surgical and anesthetic techniques. Follow-up was 2 years, and primary outcome was amputation-free survival. The BEST CLI enrolled in the U.S. and abroad from 2014 to 2019, randomizing patients with chronic limb-threatening ischemia to either bypass or BEST endovascular therapy, but patients were additionally divided into 2 cohorts based on the presence of adequate vein for bypass. Patients were excluded if they were felt to have excessive risk with open surgery. Surgeons were allowed to choose any bypass technique that was currently being used in clinical practice. In the endovascular group, interventionalists were allowed to choose any available endovascular technique. The primary outcome was a composite of major adverse limb events, which was defined as amputation above the ankle, or major limb reintervention, that's important, a new bypass graft or graft revision, thrombectomy or thrombolysis, or death from any cause. The primary outcome from the Basel II trial favored endovascular therapy with increased amputation-free survival with endovascular therapy. This was, however, driven primarily by mortality, as amputation rate between the groups were similar at 20% after bypass and 18% after endovascular therapy, while mortality was 53% in the vein bypass group and 45% in the BEST endovascular treatment group. Reintervention was higher in the BEST endovascular treatment group at 19%, whereas the vein bypass group only required reintervention in 5% of patients. The primary outcome of the BEST CLI trial favored bypass in the vein cohort. The primary outcome of major adverse limb events or death occurred in 42% in the surgical group and in 57% in the endovascular group. This was driven primarily by a difference in reintervention and, to a lesser extent, amputation. Major reintervention occurred in 9% of the bypass patients and in 23% of the endovascular patients. Amputation rate was 10% after bypass and 15% after endovascular therapy, while mortality was just 33% in the vein bypass group and 37% in the BEST endovascular treatment group. Of the almost 400 patients in cohort 2, which was the patients who did not have adequate vein, there was no significant difference between the groups in the primary outcome or in the secondary outcomes, with a trend towards increase in major intervention as the only difference. These trials represent a colossal effort to definitively answer a question that likely doesn't have a definitive answer. Is endovascular or open bypass better? It depends. The Basel II trial demonstrated that bypass in all comers is associated with a higher mortality, while BEST CLI showed that in patients without elevated surgical risk, it can have comparable mortality. It is interesting that neither trial demonstrated a benefit in limb salvage in either group, with the benefit in the BEST CLI trial largely being driven by the lower rate of reintervention. I think it is important to remember that these were patients in whom clinical equipoise had been determined by at least 2 interventionalists who could perform the procedures. So if nothing else, this does confirm that this invisible inflection point does exist, and even if we can't tell exactly where it is, we have a pretty good idea of who belongs firmly on one side or the other. So in a good risk patient with adequate vein and extensive infrainguinal disease, bypass remains a reasonable first choice. But endovascular therapy has proven not only its efficacy in short lesions and mild disease, but also its consistency in raising that bar. So which is better will likely remain a moving target. Thank you very much for your attention this morning.
Any questions?
Let's start with a virtual question here. This question, and I've got the audience mics on, so I don't need to pass that around. But the question is, could you please comment on the use of SGLT2 inhibitors for PAD risk factors, specifically type 2 diabetes, and any cardiovascular effects?
I'm not familiar with that data off the top of my head, sorry.
Okay, thank you.
Thank you for your talk, and I wonder, you showed the effect of end-stage renal disease on peripheral vascular disease. Is that independent of diabetes, or are the two interacting in some way?
That's a really good question. I don't have data that I can pull from something that's been published. So work I've done in the VQI previously has shown there is an interaction, but it's actually, they don't stack. There's a certain amount of risk that a given risk factor will contribute, and then an additional risk factor on top doesn't necessarily double that.
Okay, thank you.
There are a couple additional things here in the Q&A pod. The first of which is just a note to let folks know that the VQI has begun Can Do, which is a national smoking cessation initiative. And it's on their website, just in case people would like to check that out. I can put the link in the chat pod as well. And then a question/comment. Do you have any comment on the current quote-unquote controversy in atherectomy use that has shown up in lay press? This example is in the New York Times.
So one of the main issues with atherectomy, I think, is how repeatable it is. There's certainly some evidence that in combination with drug-coated balloons that it does have, efficacy and benefit. But in patients with a questionable indication for intervention, we mentioned, the claudicants have to be very carefully evaluated for how symptomatic they are. In asymptomatic disease, there is no role. A procedure that can be repeated almost indefinitely, every 6 months, can certainly be easily overused in patients where the indication is perhaps not strong.
Sorry, one other. What should we make of the sort of two different trials, Basel II, Best-CLI? We were actually a site participant in Best-CLI here, and we enrolled a number of patients. But yeah, the data is, I'd say, maybe underwhelming.
I think it comes back down to that question of clinical equipoise. I think it will be very interesting once additional analyses on these trials come out to see exactly what kind of lesions were considered, equally appropriate for endovascular versus open surgical therapy. Certainly the investigators, thought there was equipoise, but they might not be patients that every investigator would have thought would have done equally but well with either option.
Thank you.